Good afternoon, everybody. I'll be presenting my innovation. The title slide is here. I am Dr. Parthasarathi Roy, no financial interest to disclose. Herpes simplex keratitis has an estimated global incidence of roughly 1.5 million, including 40,000 new cases of severe monocular visual impairment or blindness each year. However, its misdiagnosis ranges from 9% to 30%. In the foregoing 7 eyes of 6 cases will demonstrate certain unique characteristics of herpes simplex keratitis which were never been discussed in literature. We believe these telltale signs will help reduce misdiagnosis and thus save precious time before initiation of appropriate therapy and save thousands of eyes from blindness. This is the case 1. You see, in A, you can see a deep stromal infiltrate with central corneal ulcer with very precise margin, punched out precise margin with an endothelial plaque. In B, you can see the profound loss of corneal sensation. In C, you can see the punched out margin. And E shows the healed ulcer. Now, case 2 is depicted in A. You see the punched out margin with a cotton wisp can be negotiated through the margin into the stroma, deep into up to the center. And in B, the case 3 is depicted where you can see a very delineated sharp margin, inferior margin shown by the arrow. And there is pulling of dye in the interlamellar space is shown in C, and D, healed ulcer. Now case 4, a case of bilateral herpetic keratitis, right eye show again very delineated sharp margin with, in C you see the plane of cleavage is shown by 2 small arrow and with a small area of desmodacil by big arrow. In the left eye, you can again see the sharply demarcated margin with pulling of dye in the interlamellar space, and the dye is reducing with the healing of ulcer is shown in F. Now case 5, again there is a deep gutter-like punched out margin all around, fluorescent being pulled in interlamellar space in B, and C shows healed ulcer. Case 6, again you see the scalpel cut as if the lower border is cut with scalpel. It is so precise. In B, you can see the interlamellar space fluorescent staining, and C and D, the healed ulcer. So our key message is, apart from dendritic geographical punctate ulcers at one end of the spectrum and neurotropic ulcer at the other, there seems to be another distinct group of infective herpetic ulcers in between. This group of ulcers may be named neuropathic ulcers. The area of cornea supplied by the affected nerve is separated from the normal cornea by a punched out border of demarcation followed by lamellar cleavage, following the architecture of lamellar-planar distribution of affected corneal nerve. Here you can see in the left lamellar-planar separation of cornea with anatomical correlate, that is lamellar-planar distribution of corneal nerve. It is taken from BJO. The lamellar separation can be demonstrated by the pulling of fluorescent dye in the cleaved interlamellar space and treatment with local acyclovir or ganciclovir and oral acyclovir established healing. Thank you.
So, how did you rule out fungal infection, fungal corneal ulcer? What kind of microbiological or molecular biologic study you have done to rule out? Either looking at it, you know that some of them is not, you cannot rule out fungal corneal ulcer.
Sir,
some of them is really, I know that neuropathic herpetic keratitis can be, but some of them look like an fungal corneal
sir, yes, it looks like, but it is a common misdiagnosis and it is a common differential diagnosis. But sir, all of the cases have some common characteristics. They have come to me after 15, 20, even after 1 month of therapy with antifungal, or antibacterial medication. These are all failed cases with antibacterial and antifungal. Most of the cases, antifungal medication has failed. These are the cases, all these cases. Next thing is corneal sensation is diminished in all the cases. Next thing, the punched out margin. That is very correlative of the anatomical distribution of the corneal nerves, as depicted by some study in the BJO. They say that the anatomical distribution of the corneal nerves are at the 3 levels. That is at the subbasal, anterostomal, and the posterior stromal. So my theory is, and that's also correlated in the clinical findings.
So we'll have
that
to wind up, please. I'm so sorry to interrupt, but
Pardon?
we're running short on time.
Okay.
So, yeah,
I think I have answered to your question that these are the ulcers which has failed with antifungal therapy. That is my
Thank you, sir.
answer.
Thank you.
Thank you so much. I request Dr. Sudipta
Yes.
to call the